Hello, everyone. I'm Muhammad, and I'm a postdoc in the Department of Neurosurgery at Washington University in St. Louis. Today, I'll be talking about tract-specific microstructural measures as derived from diffusion basis spectrum imaging that help in diagnosing and prognosticating degenerative cervical myelopathy. So, there have been work on cadaveric specimen and from autopsies that finds out that there are more inflammatory cells to the dorsal side of the spinal cord in patients with degenerative cervical myelopathy. However, there's no evidence from patients because that cannot happen. There are no in vivo methods to visualize that so far, but there is an imaging modality, a diffusion basis spectrum imaging, which basically what it does is that it constructs known diffusion basis functions, then it takes the diffusion signal from the diffusion weighted image, then it tries to fit that signal to the functions and finds out the best fit. From that best fit, it can gauge the structure of the tissue. But the question is, do region-specific measures relate to disease severity in patients with degenerative cervical myelopathy? This was a single-center prospective cohort study with 50 subjects. Patients underwent diffusion-weighted imaging before the surgery. DBSI algorithm was performed, and to know the cellularity of the tissue, there's this measure called restricted diffusion, which is really ADC thresholded at 0.3 millimeters square per second, and then tissue disintegration and edema also reflected by hindered isotropic diffusion fraction. So what it really does for the purpose of this study, because we are focusing on the inflammatory cell profile within the tissue, we're looking at isotropic tensors, which means that the water molecules within a given tissue, they're able to diffuse in all directions equally. And if we set up a threshold, then we know that these water molecules are probably within the cells. For our areas of the respective areas that we studied were white matter regions of fasciculus cuneatus, fasciculus gracilis, and lateral corticospinal tract. We used Spinal Cord Toolbox and PM50 Atlas to obtain the DBSI-specific measures from the ROIs. For quality control, we set up a z-score threshold of less than 2, and we calculated correlations between DBSI measures and MJOA subscores of sensory dysfunction, motor dysfunction of the upper limb, motor dysfunction of the lower limb, and bladder dysfunction. For the baseline characteristics, it's very typical. There were 18 patients in patients who had mild degenerative cervical myelopathy, 9 in moderate, and 7 in severe. If you look at the MJOA subscores, all of them show a similar pattern of worsening subscore as they go toward, as they progress in severity. However, if you look at bladder function, it's about similar between the patients in mild and moderate groups than severe. For quality control, we performed both within subjects and between subjects z-scores, and for non-restricted fraction, it was 4.79, below the 5% threshold that we decided. Restricted fraction was at 3.85. For the DBSI metrics within subjects, there were no images which were above the threshold of z-score. Coming to the correlations between different measures, if you look at the two charts on the upper side, it shows how the signal from fasciculus cuneatus correlates with restricted fraction measured for upper arms. And this is moderately, this is a moderate intensity signal that is significant. If you look at the bottom 3 charts, that shows the relationship of fasciculus cuneatus signal, restricted fraction signal for bladder function. This is something that we're not able to explain at this point, and we're looking into it. Coming to non-tract-based DBSI, which is if you do not extract measures from those specific tracts and use the whole white matter as your region of interest, there were no significant correlations found. Concluding, DBSI enables tract-specific characterization of microstructural injury in DCM. These findings align closely with literature from cadaveric studies, and to include the clinical variables and to be able to accurately prognosticate, we would need a larger sample size and more variables. Thanks.
So I've been asked to discuss this. So why is this a top abstract? It's a top abstract because it's filling an information gap that we don't have. Right now, routine MRI cannot distinguish between symptomatic and asymptomatic. And I put this up as a example. Both patients have cord stenosis. Both patients have on axial imaging, the cord is defaced. Can anyone say which one is symptomatic or not symptomatic? And so this has actually been published, and the top image is a patient who is symptomatic, and the second patient has no myelopathic signs or symptoms. And so this is a top abstract because for the first time, we're able to potentially use a technique to allow us to actually correlate these images with with function. And so it's really promising. Look, if you have the fasciculatus gracilis, it can be hindered. It hinders your lower extremity function. So that's why they lose balance. And you have upper motor extremity scores that correlate with signals in the fasciculatus cuneatus. You've got upper motor extremity scores correlating with the intermediate zone. You've got upper extremity motor scores correlating with the dorsal horn. You've got sensation that's affected by the dorsal horn. You've got hand sensation. So now, instead of flashing up an image and say, well, and then waiting for somebody to tell you what the clinical outcome is, maybe you can have it just based on the MRI. Now, every time there's something that's really exciting, you're always like, oh, maybe there's some limitations to it. And one of the limitations is, so this has been studied with respect to tumors and other things. One of the major limitations is with stenosis, it becomes very difficult to figure out where those tracts really are. And so here's an example. And you can see here, you can tell where the tracts are on one, and the dorsal horn on the non-stenosed image. But in a patient with myelopathy and stenosis, you're just guessing. And so with guessing, you may also have errors. And so again, this is one of the concerns. So with any study, there's always issues with single center, and all these patients were already undergoing decompression, so they were already potentially symptomatic. What happens when you assess these patients in asymptomatic? Is it going to be like, the cord signal change that we see sometimes in patients who have no signal changes? What's the natural history? What's the rate of progression? I mean, this is so exciting, and I'm really hope you continue this work, and hopefully it will be a biomarker in the future. Thank you.